Welcome, everyone. This is Pam Dunwald and Linda Criticus, your nurse advocates, and we're here with another installation of a presentation of video for our Senior Care Summit 2024. And I'm going to let Linda go ahead and introduce our guest for this presentation. Linda, go ahead.
Well, welcome everyone, and I'd like to introduce you to Dr. James Williams, MD. He is someone I have worked with on and off for some years, and he is a very, very, very knowledgeable, interesting physician who has been practicing family medicine since about 1978, but then got out of the world of the hospitals and the clinic to open up an arena of healthcare to serve individuals where they live and in the environments they choose to be in. And I'll let him talk a little bit more about his bio, but what he does is something that I think is it's a real niche and is really something that is missing, but really provides a much needed support to our elder population and to our medically fragile population. So Dr. Williams, I'm going to let you talk a little bit about who you are and what you do, and then we're going to have a few questions for you so that we can find out more about these great things that you do.
Okay, thank you, Linda and Pam. Yeah, I'm Dr. Jim Williams. I've done what I do for quite a while. I got started in medicine back when we still had index cards to write patients' notes on. And now I can keep my whole practice on something the size of an index card box. But I've always been in family medicine since, again, the late 70s, and been interested very much in holistic care, not necessarily, any particular part of that, but just being aware that medicine is a great area. It's got a lot to offer, but there's also a lot more that goes into the caring part of medicine. So worked in many office settings and thoroughly enjoyed that. And then in 2014, decided that I wanted to do something different. My mom had been in assisted living. She actually had lived with us, my wife and I, for a couple of years. And it was challenging to have her live with us. I loved her to death. I never got really tired of her. However, we were kind of like helicopter parents for little kids. We were helicopter children for my mother. And the home health nurse that came, because she had several problems, told her that she would maybe be happier and more independent in a assisted living facility. And so we went and looked at it. She thought it was a good idea. My wife really thought it was a good idea. And I was wondering, because I felt a little bit guilty about doing that. However, she did. And up until that time, when patients from assisted living came in the office, they come with a couple pieces of paper. Someone may or may not come with them. And you get a very minuscule history. And anyone who spends much time in medicine realizes that history really is the most important piece. So after a while, it was hard to get my mother out. And my partners, who were less than a mile away, didn't see fit to want to go to the home to take care of her. And being in Wisconsin, particularly in the wintertime, it wasn't pleasant getting her out. We had lived in different areas around the country and been in very sparsely populated. So I had to take care of her, my parents, at certain times. And so I started taking care of her in the facility. The first thing that I realized is that the information I was getting in my office was pitiful. Lack of a better word, it was pitiful. And that was not just my office, that was the standard of care. And so the second thing I learned is that to be able to provide care for these patients, or my mom in this setting, it meant I had to rely on the people in the hallway, the caregivers, the administrator, the cook, the activities director, to find out what this little lady was doing in the course of her day. So it became very aware this is a team sport, and it requires a real team to give the highest level of care. And so pretty soon, nobody else wanted to leave that particular building either. So I became the physician for most of the people in this particular building. It wasn't long after that that I just traditional medicine as we were doing it, which was very high quality for what it did. But I began to realize that medical care for this group of people in assisted living was really third world level care. From the best of the best facilities, it was still third world. For example, in Wisconsin, it was pretty standard care. Other places, in most places, that somebody elderly, you would see them probably every 3 months because things were changing. Well, and particularly in Wisconsin, you would see them in October and say, come back in the spring, because who wants to go outside in a Wisconsin winter? And so they would do that. Well, then it becomes common knowledge. Well, we don't need to have mom seen, but twice a year, spring and fall. Well, we realize that things change a little faster than that. So anyway, I proceeded to realize that my new calling was to get out of the office and go into the facilities. And that's what I started doing. Initially doing nursing homes and assisted living, realizing pretty soon there's plenty of people who will go to nursing homes, plenty of doctors, providers, nurse practitioners will see patients in the nursing home. The patients in the assisted living, at the time I made this decision, there was only one other organization. There were two, but one decided to close shop and leave. So, for thousands of patients, there were only two organizations now, mine and another one, providing any level of care in northeastern Wisconsin. And so I started doing that, and it's just been a incredible, interesting, and rewarding ride ever since. So that's how I did it. Basically, I realized patients were getting third world care. It wasn't good enough for my mother. It wasn't good enough for anybody else if I could help. So that's what we did. Go ahead, Linda. Pam.
Yeah. So my question to you is, I mean, that is a really unique niche. And I know just from the work that I do and working within some of these environments that it provides a much needed service. Tell me how you have taken that beginning and kind of evolved it into some of the specialty things that you do for some of these individuals in regards to telehealth and telemedicine and getting a good response time instead of having them go out to the ED, because everybody knows sending them to the ER or to the emergency department and sending them to the hospital is not really what they want to do, and it's not really where they want to be. And with the work that you do, your response time and your visits that you make kind of help curb some of that movement. So how did that all evolve?
Yeah, well, I think a lot of it evolved with, again, just a mindset of, practicing in a way that if it wasn't good enough for my parents, it wasn't good enough for anybody. That was a big mindset for a long time, because I was being blessed to be a physician and being able to help my parents. It just made a big difference. And so when we started doing this, part of it was still, we needed really, really good Wi-Fi, and we could do basically the traditional way. You interview a patient on site, and you interview them, and then when you get home or whatever, you dictate some notes, which was better than nothing, but it was still slow and, again, limited by, if your market goes from 50 to 75 miles in every direction, or a diameter, of 150 miles, you can't be in two places at once. But we tried. And the best we were able to do is to see people traditionally once a month. And again, once a month, because our people are changing rapidly, just like infants. When infants are born, they see the provider, monthly for a little while, and then they every couple months for a little while. Well, this is just the opposite. Things are changing quickly. And so we see them monthly for preventive purposes, primarily for prevention. I've always done wellness and prevention, which means, eating right, whatever, exercising, not smoking. Well, in this population, wellness and prevention is making sure they don't have painful calluses on their feet, so they have pain and they fall down, or making sure that the medicines they've been taking for the last 20 years that they really still need. Some of our patients are in their 80s or 90s. These medications are designed to keep them living for another 20 or 30 years, or prevent problems for another 20 or 30 years. Well, not likely they're going to have that problem. So let's get rid of it, because they're not getting a benefit, but they're getting the side effect potential. So a lot of wellness and prevention, a lot of training and teaching, because so many of our folks have been raised in traditional medicine. And you need to keep your cholesterol at a certain level. You need to keep your blood sugars well controlled, which again, in this population group, the well-controlled blood sugars of keeping them from too high will, for the most part, protect them in the next 15 to 20 years. But that low blood pressure will take them to their final home today. So, a lot of those things. And so we did that for several years, because that's really the best we could do. The other thing we could do is be available when someone called us in between those visits, because there's always problems. And part of the challenge, a big part of the challenge, is that unfortunately today, in some of the best hospitals in Wisconsin and probably around the country, the providers, the doctors, nurse practitioners, don't know the difference between a skilled nursing home and an assisted living. And so, and I know that because I get discharge summaries that say patient came in from a nursing home. No, they didn't. Or they're going home to a nursing home. No, they aren't. Which doesn't sound like that big a deal, except when a provider calls a facility, an assisted living, in the middle of the night, and they don't get a nurse, and they don't get the things they need, they sometimes tend to get irate, which then makes that person hesitant to call back, which means our loved one is not getting the attention they need. So providing a level of care where we are appreciative of what's going on in their home.
Dr.
So
Williams, that
yeah.
brings up a question for me. So when we were talking about that, not knowing the difference between the assisted living or nursing home, I mean, this might be a good time to mention about what are the risks of those transitions in care do you see when people have gone from a hospital to a nursing home to home or assisted living? What can happen during those transitions?
Well, it's the what can happen is huge, and the evidence for that is based on the fact that Medicare has realized that there are a tremendous number of errors made during that transition from the hospital to the assisted living, not so much from the assisted living to from the nursing home. Let me back up. So from the hospital to the nursing home, tremendous problems. And then from the assisted nursing home to the assisted living, tremendous. So Medicare has programs in place called transition of care, where you're not required, but if you see that patient within the first 7 days and do a few other things, they will reimburse you a lot more money. You got to talk to people. You have to make sure you have the information. all in an effort to make that transition better. Hospitals, because of Medicare guidelines, are notorious for wanting to send people home on Fridays. If you have a loved one, never let them be discharged on a Friday. Never let them be discharged on a Saturday or Sunday, because there's nobody there. There's nobody there.
There
You know,
isn't.
other than the routine healthcare and the assisted livings, different from nursing homes. Nursing homes always have a supply of medicine on hand that they can give. Assisted livings, if you don't get it in by Friday, the majority of them will not be able to get that medication until Monday night, Monday night. So again, being able to know these things to make that transition better. But one of the things I always tell the POAs, you know, the power of attorneys or the families, don't ever let a hospital discharge you on a Friday, Saturday, or Sunday. Just don't. Fight it, stand your ground. You may have to pay an extra day at the worst, but don't let them do it, because it's just so dangerous. So there are a lot of things. And so, you know, we're able to get the hospital records virtually immediately. We can go into the medical records of the assisted livings and see that the hospital discharge summary, the pharmacy records, and our records are all, you know, on the same page, because, you know, there's almost always at discharge a difference between what the patient went in on and what they're coming out on. And because we have this thing, the number one thing is called Epic, which is the hospital's medical record system. Most people don't realize, but God lives in Epic. Once it goes into Epic, it never comes out. So they may come home on a medication that they were on 10 years ago, but along the way it was stopped. But if you're not paying attention, so, you know, the medication thing is a big one. Reconciling the medications, doing a thing that nobody ever really talks about, which is de-prescribing, having those conversations, because, you know, with the family members, you know, it's really time to maybe stop that cholesterol medicine. You know, there's good evidence that, well, there's no testing beyond 55 or 60 some years old, and we have grandma on it at 98. But I was told to always take this for the rest of my life. Well, not so much. So having that conversation, some people are open to it. Others say, well, I know Dr. Google says, my doctor always said. And so, but that de-prescribing is so critical, because patients are getting things that are serving no benefit, but they're still getting the risk of side effects. Number one side effect, falls. You know, and you know, we mentioned falls, and you know, falls are inevitable. That they are. I mean, it's going to happen. Jimmy Carter, our previous president, had 3 falls in 1 week. He's got to have great medical care, but he had 3 falls in 1 week. Had a bleed on his brain, and that's as good as it gets. So we are going to have falls, but there's things we can do to minimize those falls. Medication side effects is another thing. You know, there's pretty well-known fact that all medicines, everything has a side effect, but all medicines have side effects. When you add a second medication to the first medicine, you've got a lot more side effects. When you add a third medication, there's a lot more potential side effects. And most of our people have how many medicines? 7, 8, 10, 12.
A lot
13.
greater than 5. Most of them greater than 5.
Yeah. So de-prescribing is a very important thing, but that requires conversation with the family, hopefully some education with the family, because again, that's a critical thing. And there are big courses available on that. So those are some of the things. But then along comes COVID. Everybody tends to hate COVID, thinks it's the worst thing in the world. However, for the medical community, even hospital care, telemedicine is a godsend. Fortunately, because of the system we used, the moment the president said we could do it, we were doing it the next day. Psychiatry has been doing telemedicine for years, decades, quite successfully, for the most part. And so we were able to do that. And I think at this point in our practice, we've probably done somewhere around 7,000 telemedicine visits, maybe more, but at least 7,000. And because we've had our records reviewed, and I've got like a hospitalist and some other internists and different things that look at it. And probably the biggest fact-based thing is Medicare still thinks, after COVID has settled down, that telemedicine is a good thing. Medicare considers delay in care a huge negative thing. Delay in care is a bad thing. And so I would guarantee almost that anybody on this visit, on this call, or who hears this, will have made an appointment with a provider sometime in the last couple of years. And you rarely hear, oh yeah, we have an opening tomorrow. That may happen. Yet the typical, I heard it today. I had a patient, one of my patients that ended up in a nursing home, and I still follow her family, because she's seen a psychiatrist for years. She's on hospice for something else, but she's seen her psychiatrist for years. She can't leave the nursing home, and now she can't see the psychiatrist because they no longer do telemedicine visits in their practice. I don't know why, but they don't do it. And the family's concerned because she's having some behavioral issues. And based on everything they know, the best place to go is to her psychiatrist, which might well be. However, the psychiatrist says, we'll see you in 3 months. That's our first opening. We'll see you in the office with your heart failure, respiratory failure, and your other mental health issues in 3 months in the office. Well, that doesn't make a lot of sense. And particularly when, for someone who has a modicum of patient care in family medicine, internal medicine, especially in Wisconsin, but across the country, there's a lack of psychiatry services. And the psychiatry service she had, when she could do telemedicine, it wasn't video. It was a hospice nurse able to give a little bit of history, and then talking to this patient that also has dementia. And that's what the treatment is based on. So it's really problematic. But what that allows us to do, if grandma falls Sunday morning at 2:00 in the morning, and she happens to be on a blood thinner, or just because it's policy for the facility, not policy based on a medical program, but a policy, i.e. to prevent getting sued. If you fall and you hit your head on something, you're going to the emergency room. In the emergency room, they check you over pretty quickly. We'll do a CAT scan. If the CAT scan's negative, they're going to send you home. If the CAT scan shows, oh my goodness, you've got a bleed in your head. Most bleeds aren't going to be huge. They're small. And they're in their 80s or 90s. And the neurosurgeon says, let's watch this. Go back home and we'll watch it. Well, with telemedicine, the minute she falls, the nurse or the CNA, the caregiver, can get us on their personal or anybody's phone and give whoever's on call, myself or my nurse practitioner or whatever provider, a call. And in 10 minutes, we can do a complete neurologic exam, a complete orthopedic exam, and say, oh, by the way, there's a bone sticking out, you better send them to the hospital. Or no, there's no bone sticking out. patient looks stable. Let's recheck them in an hour, or let's recheck them in 2 hours, or we can check them tomorrow. Doesn't matter. You know, that's better care than they're going to get in the hospital. So we can see them. And if something changes, we can send them to the hospital. But typically things don't change. And they've avoided a problem at the hospital. And I say a problem at the hospital because the second thing that people don't realize is that the hospital will immediately do a urinalysis. Patient had a fall, they had a change in condition, let's do a urine. They do the urine. It looks a little bit, maybe there's an infection, maybe there's not, but it doesn't matter. It looks bad. Let's put them on an antibiotic. Well, now we've got a second problem because statistically, they don't have a urinary tract infection. And now they're on a powerful antibiotic for the next 5 to 10 days. Okay. So, I've had nurses say, well, what's the harm in putting them on antibiotics? Well, like the top 3 or 4 causes of preventable death are inappropriately prescribed antibiotics. So now we've unnecessarily gone to the hospital. Now we've got a misdiagnosis for urinary tract infection. And now we have Clostridia difficile for something that didn't have to happen. So we get to do that. Also because, again, if I had my greatest wish, every patient would have a provider, doctor and nurse practitioner that go to the assisted living. There's so many that we can't possibly see them all. The other organizations that do something like this can't possibly see those people. So my greatest wish would be everybody would take care of their patients in the office when they can and on site when they can't. They would get the same level of medical care. So the telemedicine is just amazing. I mean, it really is. A lot of times people think, well, I really want my mother to be seen by a doctor who sees her. Okay. You're going to go to the ER, you're going to go to the urgent care, or you're going to wait. And while there is a huge benefit for me to see a patient, there's not a documented benefit for the patient to see me, whether, by in person. So it's an incredible gift. And we all should, and we can, have a Bluetooth stethoscope so that we can hear what's going on in their chest. We can get x-rays on site. We can get blood work on site. And oftentimes at least have the visit and the x-rays done before they get seen in the hospital. So it's an amazing gift. We can
Dr.
also
Williams,
do, yes.
I was saying, Dr. Williams, I think you've made a really, even to me, you've made a really strong point for the benefits of telemedicine. What do you do, or has it come up where you've had any challenges with our aging population being able to utilize technology or say a smartphone? How do you get around that?
Well, that's a great question. And obviously, we don't live in a world of Burger King where you get to have it your way. Because if that were the case, everybody would want to be seen on site the moment they want to be seen. But we know we can't do that. But, within that, the way we do that is obviously, for the most part, particularly for regular visits, we have someone, a patient caregiver that goes to the facility after they've talked to the family and after they've reviewed the medical records. And then at the facility, they talk to the caregiving staff, and then we see the patient, and they help us do the visit. Now, and we do them with patients that can't see, patients that don't realize what we're even doing, or some patients who really do know, and some like it and some don't. Well, and I understand that. Some like it, some don't. The outcome of that visit is equally as good And most people over time will begin to understand the benefit. It's a lot of fun. I mean, because we can get all the information we need, but we do have somebody there doing it. For the urgent visits, 50 miles away, 60 miles away, for the urgent, we do rely on the facility staff. If they have a smartphone, the cook in the kitchen can run the visit. It's no different than doing FaceTime, except it's HIPAA secure. It's safe. It meets all the criteria for HIPAA, and so it's confidential. But really, seriously, a cook in the kitchen I've had cooks in the kitchen. I've had maintenance people, because there just weren't people available to be able to help me do a visit. And for me, that's so rewarding, because they come to the office in a few days, maybe, or a week or two, or urgent care. But I, as the provider, don't need my office. I don't need a nurse. I don't need all these things. I can just take my smartphone, create an encounter, see the patient, finish the visit, send their medicines to the pharmacy, and 20 minutes later, I'm back asleep. And the patient's taken care of. It's just crazy.
It's amazing.
So where there's a will, there's a way.
Yeah, the response time almost seems like, it's like, why wouldn't anybody want this? Because the response time for care is not delayed anyway. The response time, it's rapid, really. It's a rapid response time because of the way that you can deploy the technology. It's kind of a win-win for all parties involved, especially the patient themselves, because they're not sitting in an ED for 3 hours waiting for somebody to see them or to check them out. And a lot of times when individuals are sent out because of a fall or because that's the protocol, they will go to the ED. But if there's somebody else that's a higher priority, they could sit there for 8 hours before they're even seen.
Yes.
And how uncomfortable is that?
Yeah, sitting in a chair, laying on a stretcher, that's all uncomfortable. And I haven't seen the documented evidence. However, because the patients are sent out, because, perhaps a nurse who are very qualified to do what they're trained to do, but because they're somewhere else and they're getting a call and they don't want to miss anything. And the consistent thing that you will hear is, well, I just don't know what's going on. I don't want to miss anything. Send them out. There's no harm in that. Well, there's accidents. There's all kinds of stuff that happen, but it's also a $5,000 to $10,000 investment of taxpayer dollars. And the greatest majority of those send outs are going to come back.
Yep.
Typically not paid for. The emergency transfer is paid for. The non-emergency transfer back may not be paid for, which could be $1,000 or more out of somebody's pocket. And worst of all, nothing changed. They go out and they come back. Nobody's really concerned much because we took care of it. And so it's really because people don't understand. And again, the fallback there is, or I guess the challenge is, even though we tell people we can do it, it's still, old habits, old conventions die very slowly. And so, in my mind, I've come to accept that most people aren't going to do this right now. Hopefully, along the way, somebody will pick it up and it will gain more and more momentum, which will be good, because our elderly deserve it.
Dr. Williams, that brings up a great point. We have some speakers actually from 10 different states, so people could be watching this from many different parts of the country. So do you know of any, are there other providers like you doing similar things? Is it safe to say that maybe someone in an area, they should seek out and see if there is a provider in their area that is doing something similar?
Absolutely. I mean, I think the aging and disability would have some information on that. That's probably going to be one of the big ones. Some of the homes that patients are going to may have somebody coming in, because there are other organizations, and there are organizations that do things, who do come to the home. They come once a month. Now, what happens the rest of the 29 days or 30 days, I don't know, but they come once a month. What I do know, if it's a real problem or any problem, it's handled by telephone for the most part. And the safe side of that is, well, I'm not sure, send them in. Or, so within that, there are a lot of different organizations. A little is better than none. So if people are going in once a month, at least that's something. It's a start. But I think at the end of the day, particularly at a time when the system has changed dramatically. When I started, there weren't assisted livings. There were country homes or county homes where people went to die. There were nursing homes where people went to die. Hospice wasn't around. But the only real true medical care was you had to go to the doctor. Well, things have changed. Society has changed. And, the real question is, why do in my mind, some of our most valuable citizens, everybody's equal, why do they deserve third-class care? And the reason is that there's no incentive for particularly the bigger systems to do it. And it's hard. It's very easy to sit in your office and have everybody come to you. And there's a place for that. Yet our frail elderly need their own place. They need their own system. And so hopefully, as we do this and the word gets out more and more people are coming in, because it is rewarding. In many ways, it is less hassle. But so it is growing. I think there is a move, but we got a lot of moving to do.
Hold on. I just want to make one comment here. It's really, you have such a highly developed niche in regards to this. Your technology is a lot more advanced. I've worked with other like home physicians or physicians that go to the homes and assisted livings, and a lot of them, it's very simplistic in a lot of ways. So I just want to let people know that they really need, when they're looking at this, they really need to ask questions and do some due diligence, because you're right. I mean, they come out once a month, but sometimes you can't get a hold of them to get a prescription, or their answering service will say, well, they were just out last month, so if they need something, they need to go to the ED. Or we took care of all that and there's nothing more we can do. So, and I've had those experiences working in home health with other providers in regards to these types of things. So I just want to give you kudos for this, because you are way above you've raised the bar, and you're way above the norm on some of these types of situations in regards to the care that you are providing and the quality of care and the response time to the care that you're providing to our population.
Dr. Williams, I'm sorry.
No, go ahead.
This is my favorite scenario. My last hospital position, I worked in case management, worked with the discharge planners. So we send a patient to the nursing home, and it's really sad for me to have to say, while I have the nursing home on the phone, okay, you're putting them on the list right now for the provider to see them within the next few days. You're putting them on the list, right? And then only to do a follow-up call and say, well, we didn't know they were supposed to see the doctor right away. Well, somebody didn't put them on the list. And I mean, it's just simple things like that are just extremely frustrating, but you've demonstrated an amazing way to address that.
Well, thank you. I think I've been very blessed. I had, great training in my family medicine residency. I was blessed with understanding that, we're all equal, and we all, if a provider were to get sick, are they going to wait a month, 2 months? No. So, we treat ourselves or treat others the way we like to treat ourselves. And today, there really is no reasonable excuse not to be able to do the things that we do. There's no reason an urgent care system can't go see the patient. So, I'm glad y'all are doing this. Again, I'm just blessed to be able to do it, and to see this come up. And, part of the other reason that we can do this is we have such an incredible electronic medical record. It allows us, when president said do telemedicine, all we had to do was flip a switch. There's so many things that it's just, we've been blessed in many ways. But the biggest thing, I think, is the desire. There's always excuses, and there are always reasons, but we all know that if we want something bad enough, we can do something. And so I'm just blessed to be at this point in my career, by good people. We've not met Pam, but Linda and I have. And the other thing that Linda was mentioning about going in once a month is, if you get admitted on the 1st and their last visit was the 28th, you may have a physician for a month or a nurse practitioner for a month who's never seen you. And now there are home health orders, physical therapy orders that need to be completed, but the physician or provider hasn't seen them. And so you cannot get the paper signed.
That's right.
And so now our loved one who needs physical therapy or home care gets the pleasure of waiting 30 days to start the therapy after their problem. And these are things people just don't necessarily see, but it's a fact, and we all go through that. And so, I'm just blessed that we can do this, and hopefully the bar will continue to rise.
Right.
Thank
I mean,
you.
because
Linda,
your response time is wonderful. I mean, and I know that, and I've seen that personally with some of the residents that have been under your care. I mean, the response time to get things dealt with quickly, and urgently, because you're right, Medicare does not want to see a delay in care. They do not. That's why home health has to be in there. Once we accept that case, we have to be in there within 48 hours. No ifs and buts or maybes about it. So to be able to have that response time, to be able to utilize that telemedicine, to be able to get the things that we need, to be able to admit that person into the appropriate services. So again, it's the right time, the right place with the right skill set, right provider, right care. And that improves clinical outcomes all the way around.
Yeah, absolutely. I mean, and for, again, 35 years of my 45 years, people would wait in the office for a couple of hours. I mean, you have to take care of what you have to take care of, and nobody wakes up in the morning and says, I'm gonna make everybody wait 2 hours, but it's just the way life works. You all had to wait for me today for about an hour because of the way life works. And so, but within that, now you don't have to wait. Will you get a lot of reasons from different people? Absolutely. But is there any facts of life that really stop it? Not at all. I don't think we're special. We just saw the opportunity. We have the desire, and I've got, a team of 16, 17 people that all feel the same way, from computer people to nurses, all of these things. Oh, I forget one last thing that I forgot to mention, and that's a thing called, two things called CCM, or chronic condition management, and remote patient monitoring. And the chronic condition management is a system where providers can now actually get reimbursed for all the things that you couldn't, like for the phone calls after hours to the families, for the phone calls to the nurse or to the caregiver. All of those back office things that we never got paid for, but we did. Fortunately, our electronic system allows us to do that, so that we can now allow our nurses, our aides, to do the right thing, and we can afford to pay them. So that's a great thing. And then remote patient monitoring, again, being able to monitor their blood pressures and pulse and oxygen levels 24/7 is a great thing also. So anyway, thanks so much.
Well, Linda, is there anything, or Dr. Williams, anything in wrapping up that you'd like to say before we close?
Linda?
I just think what you're doing is a phenomenal service. And I think everyone, as you said, needs a provider kind of this way to be able to give them the response time that they so deserve. Our elder population is so medically fragile and so much more complex than it was. I really believe that the services that you provide, so that you go to them instead of them trudging through snow and two people assisting them, devices and walkers and wheelchairs and Hoyer lifts and all the things that takes to get them to the doctor, which is truly exhausting. For you to be able to go to them, it is truly a godsend. And I really think you have raised the bar for other providers doing the same thing in regards to what you are doing. So I just want to say kudos to you and keep doing it, because I
Well,
like
thank you so
working with
much.
you doing it.
Well, thank you, Linda and Pam. Yeah, again, I can't share enough that it really has been a gift, and we are blessed. And one of the most difficult things for a provider to do is to break away from a medical system. There are a couple medical systems that do in-home things. They go in the once or twice a month, maybe, but after hours, you're at the beck and call of the. There hasn't been a major effort, and finances aside, when you see the looks of many of these humongous medical buildings, you got to get people in there. I don't know what the real reasons are, but I do know it's possible. I think there's opportunity, and families, checking with ADRC and all the resources out there, don't hesitate to ask, look, Google, call, whatever, because your loved ones deserve the best.
Well, thank you
Thank
so
you.
much, Dr. Williams, for taking the time to visit with us and to shed some light on telehealth and to shed some light on what you do. We really, really appreciate that. And so for those that are watching, we're going to go ahead and end this presentation, and we will see you on the next Senior Summit 2024 video. Take care.
Bye-bye.